Shoulder arthroplasty. Published by WordPress.com. Shoulder arthroplasty. Shoulder arthroplasty is a surgical procedure used to treat various shoulder joint pathologies, including arthritis, rotator cuff arthropathy, and fractures. The procedure involves replacing or resurfacing the glenohumeral joint with different types of prosthetic components depending on the indication and condition. Types of shoulder arthroplasty. 1. Resurfacing. Only change articular surface of head humerus with metal surface attached to screw, failure rate very high. 2. Hemiarthroplasty. Involves replacing only the humeral articular surface with a stemmed humeral component. Indicated for arthritis or fractures of the humeral head when the glenoid is intact. 3. Total shoulder arthroplasty, TSA. Replaces both the humeral head and glenoid with a prosthetic component. Typically involves cemented all-polyethylene resurfacing of the glenoid as standard of care. Indicated for arthritis with intact rotator cuff, arthropathy, and certain fractures. And 4. Reverse shoulder arthroplasty, RSA. Uses a convex glenoid, hemispheric ball, and concave humerus, articulating cup, to reconstruct the glenohumeral joint. The center of rotation, core, is shifted inferiorly and medially to allow the deltoid muscle to act on a longer fulcrum, providing more mechanical advantage. Indicated for rotator cuff insufficiency or arthropathy, particularly when the rotator cuff cannot be repaired. Prerequisites for shoulder arthroplasty. Intact glenoid. A critical component for most procedures, particularly hemiarthroplasty. Intact and functioning rotator cuff, especially important for TSA. Good glenoid bone stock inversion. Adequate bone quality is required for proper implant fixation. Deltoid function. Appropriate for reverse arthroplasty. Glenoid wear. Should be assessed for suitability in arthroplasty. Indications. Arthritis with intact glenoid. Suitable for TSA. Rotator cuff arthropathy. A common indication for RSA. Avascular necrosis, AVN. With intact glenoid, RSA may be necessary. Proximal humeral fractures. Suitable for hemiarthroplasty or TSA depending on fracture severity. Rotator cuff insufficiency. RSA is often the procedure of choice. Comminuted proximal humeral fractures in the elderly can be treated with hemiarthroplasty. Failed arthroplasty. If previous shoulder replacement fails, revision surgery may be required. Contraindications. Glenoid involvement. Hemiarthroplasty. If the glenoid is severely damaged, TSA may be preferred. Insufficient glenoid bone stock. Poor bone quality may prevent adequate fixation. Coracoacromial ligament deficiency can lead to superior escape of the humeral head. Irreparable rotator cuff. In cases where the rotator cuff cannot be repaired, RSA is often indicated. Plasty. Published by WordPress.com. Complications. Glenoid loosening. A common complication, often related to the implant design or bone quality. Scapular notching. Caused by impingement between the humeral cup and the scapular rim during adduction. Increased risk with superiorly placed glenoid components. Dislocation. Anterior instability is a risk, especially with irreparable subscapularis tears. Tuberosity displacement or malunion can affect the stability of the prosthesis. Subscapularis repair failure can lead to dysfunction of the shoulder. Progressive glenoid arthrosis can occur over time, leading to the need for revision surgery. Surgical techniques. Deltopectoral approach. Common approach for shoulder arthroplasty, involving an incision along the deltoid and pectoralis muscles. Autograft or allograft. Used to address glenoid deficiencies, including retroverted glenoid or bony defects. Osteotomy at the medial insertion of the supraspinatus may be required for certain fractures or deformities. Retroversion correction, typically addressed with posterior glenoid reamers or grafting. Classifications. 1. Walsh classification of glenoid wear. A1. Minor erosion. A2. Deep central erosion. B1. Posterior wear. B2. Severe biconcave wear. C. Retroversion greater than 25 degrees. 2. Servo classification of scapular notching. I. Limited to the scapular pillar. 2. In contact with the inferior screw of the baseplate. 3. Extends beyond the inferior screw. IV. Extends under the baseplate, approaching the central peg. Key considerations. Postoperative rehabilitation. Essential for achieving optimal function, especially for rotator cuff repairs and ensuring proper implant alignment. Patient selection. Carefully assess for adequate glenoid bone stock, rotator cuff integrity, and the extent of arthritis or fracture to determine the most appropriate surgical approach.